Okay, so here we have the module on impulsivity, compulsivity, and addiction. We're going to go through these disease states and talk about all the pharmacotherapy for them. Let's see. As soon as PowerPoint catches up with me. Okay, so neurotransmitters involved in substance abuse, they're ones we have talked about before. Mainly, there's dopamine, which leads to our pleasure senses. That is what gets stimulated when people do illegal substances like cocaine. We have norepinephrine and serotonin, GABA with abuse of benzos. Glutamate is excitatory, NMDA is excitatory. You have cannabinoids, which hit the cannabinoid receptors, and then neuropeptide Y, which is being studied for satiety, anxiety, and mood. When substances are used chronically, even prescribed medications, there becomes an imbalance of these neurotransmitters. So there is a difference between addiction and dependence. I want to make that very clear. Addiction is where an organism engages in a compulsive behavior, which is then reinforced, and they lose the control of limiting intake. So, when the amount of medication or illegal substance you have to take is it can't be controlled by the patient anymore. It is, it's interfering with daily living skills, or they're spending their money on that instead of food and housing. That's where you're reaching addiction level. But dependence is a state in which the organism functions normally only on the presence of a drug. So you'll have patients who will become dependent on benzos, but they're not addicted to them. It is not a true addiction. It will manifest as a physical disturbance or withdrawal if you remove it. And you can see that, even medications that cause that dependence are, clonidine and antidepressants, because you have a withdrawal, if you were to come off those cold turkey. So you can have a dependence to the medication without it being an addiction. So treatment of substance abuse disorders, the general principle is that the body is always trying to maintain a balance or homeostasis, and chronic use disrupts that. So we're going to use medications to target neurotransmitters that mediate the reward system so that they don't get as much benefit from taking the medication or taking the illegal substance that they're addicted to. We want medications that have a low abuse potential and that are safe in overdose, or if they're combined with substances of abuse. And they won't lead to overdose in combination. So initiating abstinence is very hard to do. So you're going to need to rely on peer support groups and detoxification. And maintaining abstinence is very, very difficult. There's a high percentage of relapse. So long-term medications and peer support groups such as AA and Narcotics Anonymous are very helpful in this. Alcohol dependence is very common. Like we've said, that the body is always trying to maintain balance. Even with alcohol use, it's not an illegal substance as long as you're of age, but even that creates a dependence. An increase in GABA from alcohol leads to the body increasing glutamate to restore that balance. So when alcohol is stopped and GABA decreases, the glutamate continues and causes like too much excitatory response from that transmitter. So, what happens after you stop it? So, withdrawal lasts from about 7 days after. You can see from the chart on the right when the symptoms come into play. You're going to have increased anxiety and blood pressure and pulse. You're going to have flu-like symptoms right about a day and a half. Hallucinations and seizures at about 2 days. Delirium tremens. Hyperthermia, and then it can lead to death. Alcohol withdrawal is one of the deadliest forms of withdrawal, even of illegal substances and other medications. 50% of untreated delirium tremens will die if a patient gets to there. So how are we gonna treat it? Or another reason we have to treat it is alcohol withdrawal is life-threatening, also because of the hyperthermia. So essentially, the thermostat in the brain gets stuck at hot. The body tries to compensate opening up all the blood vessels to cool off. The veins can't pump the blood, and you have cardiovascular collapse, which leads to death. You never know which patient will have a bad withdrawal, so you want to monitor the cardiovascular outputs, blood pressure, and pulse. As an indicator when to increase treatment. So it doesn't really matter exactly, it's not just because you drink more alcohol than someone else doesn't mean you're going to have a worse withdrawal. You need to take everybody who has alcohol dependence as a potential patient for a bad withdrawal. So treatment of choice is benzos. Ativan or lorazepam is the most common because it's safe in liver disease, which most of your alcoholics are going to have. You can also use Valium, so it's a long-acting benzo, and chlordiax epoxide or Librium can be used. You'll see what's common about those is that, or the same about those, is that they are all longer half-life benzos. You are not using alprazolam or Xanax because it has such a short half-life. So you're going to want to give enough to decrease withdrawal symptoms and then taper them over 3 to 5 days. Often done with the use of a clinical institute withdrawal assessment to help understand how well you're controlling your patient's symptoms. Every once in a while, or for second line options can also be anti-kindling anticonvulsants, which can be used if a patient can't tolerate benzos or if they need additional medication. So here you have those benzos. Pros of benzos is they're effective. The cons is you have risk of diversion and abuse. The anticonvulsants, which are not FDA approved, that are those anti-kindling anticonvulsants, are carbamazepine, phenobarb, gabapentin, and valproic acid. And they can be effective. They're not typically abused, but there is less clinical experience with these. Typical withdrawal schedule you're going to see here. There's an example for benzos over a 3 to 5 day benzo withdrawal. There's one for all the anticonvulsants. If you're using those, you can still use a benzo PRN. You're not going to have a large, enough of a drug interaction to preclude you from using both benzos and anticonvulsants. But you always want to monitor vital signs and the withdrawal assessment. Adjunctive medications that'll help: thiamine for 14 days because alcoholic patients will be thiamine deficient. A multivitamin, folic acid, and magnesium 1 gram IM times 1. Those are always good for a patient to have. It's not going to hurt them if they have a therapeutic level already, but most likely they're going to be deficient because they've been getting a lot of their calories from alcohol and not from actual food. Medications to prevent alcohol relapse. These three are the FDA-approved agents. Naltrexone, which blocks opioid receptors and diminishes the positive effects. Acamprosate, which appears to help restore the balance of glutamate and GABA. And disulfiram or Antabuse, which basically makes you vomit if you come into contact with any alcohol. So when we talk about that, that's important because even alcohol on your hands to disinfect, mouthwash, medications that contain alcohol will cause this reaction, and it essentially produces it's a negative reinforcement for patients, and we don't see it used as often as we used to. It's mainly for patients who they want to have that negative reinforcement to help keep them strong, and then you kind of have that bad taste in your mouth. So, disulfiram, it inhibits the acetaldehydrogenase enzyme, so it leads to the disulfiram reaction. You're going to get flushing, throbbing headache, respiratory difficulties, nausea, copious vomiting, sweating, chest pain and palpitations, blurred vision, and confusion. Usually that copious vomiting and the flushing is what the patients are going to get the most. But if it is severe enough, it can lead to a heart attack. So you want to have a patient who is very motivated to use this and who wants to take the disulfiram so that when they're feeling weak and they have a beer, a shot, some wine, they get that negative reinforcement. Not somebody who's going to go on a bender and then have a really severe reaction. So this is for a patient who's highly motivated to remain abstinent, has good judgment, and are not very impulsive to where they go on those binges. Warnings: severe renal and hepatic impairment, cerebral vascular disease, and cerebral damage and psychoses, current or history of, duration at least 1 to 2 weeks after last dose, given because that's how long it takes to, it will stay in their body. It will work for 1 to 2 weeks after their last dose because it takes that long to regenerate that, for the body to remake that enzyme. Here are your adverse effects and drug interactions. Basically, it's medications that contain alcohol, including cough medicines, topical hand sanitizers, anything like that is going to cause this type of reaction. Here are your guidelines. Should never be given without a patient's full knowledge and understanding of the consequences. Use a written consent form so the patient knows what they're getting into. Have a patient an ID card that says they're on the medication, so that if they go to the hospital, they're not given something with alcohol in it. You want the patient to be abstinent for at least 12 hours after or before their dose. Average dose is 250 to 500 milligrams, and you should stop it in the event of a relapse. Clinical considerations: it doesn't work if you don't take it. That's the big point to tell your patients. Some may still be able to drink while taking it. So like a planned off day for, like for the Super Bowl. I'm doing really good, but I want to be able to have a beer with my friends and go to the Super Bowl. So they won't take it, that morning, maybe the day before, and then Monday morning they start taking it again, knowing that they're going to have that negative reinforcement. Here you have your contraindications, which we've mentioned before, and your patient education, which is a repeat of what we said before. Naltrexone is an opioid antagonist with a high affinity for the mu-opioid receptor. It blocks the euphoric effects of alcohol and has evidence for decreasing cravings and relapse rates. It comes in a 50 milligram oral tablet you can take daily, or a 380 milligram IM every 4 weeks injection. Do not use it for severe liver impairment, and obviously it interacts with opioids. They're not going to work in a patient who has naltrexone. So somebody who requires opioid medication is not going to be a candidate for naltrexone. Now, naltrexone is very, very effective for patients. Your patient should be opioid free for 7 to 10 days and have a negative urine drug screen prior to their first dose. But it's really good for heavy drinkers because it'll help them drink less. They get less pleasure from it, and thus help them start to decrease the amount they're drinking. The patient should always carry an ID card or a bracelet saying they're on this medication, because if the patient's in a car accident and goes to the hospital and they try to give them pain medication, it's not going to work. And naltrexone's already blocking those receptors, so they'll have to use something else. Another type of, a nerve block or something like that to lessen the pain. The big drawback from the injection is you can't get it out. So if they're in an accident, you have to go with a different strategy for pain management. But it's very good for patients who need long-term treatment. And you always want to do the oral first before you give somebody monthly naltrexone. Here's your side effects and your pain management alternatives. Contraindication: obviously if you require opioids, severe liver disease, and there's a black box warning for dose-related hepatocellular injury. Acamprosate modulates glutamate function, and so it helps restore the GABA-glutamate balance. It reduces neuronal hyperexcitability that occurs after acute alcohol withdrawal and the time period when relapse is very high. There's no anticonvulsant, antidepressant, or anxiolytic effect, so most patients don't feel like they're taking anything as far as side effects go. Onset is rapid, duration is variable, and the adverse effects are usually maybe diarrhea and insomnia when they start taking it. It should be used in conjunction with other behavioral therapies. Initiate after detox. It is 2 tablets 3 times a day, with lower doses for kidney dysfunction, and you can continue to take it if they have a relapse. So this is good for patients who like to take something multiple times a day. It's a reminder of the work they're doing, and that the medication is helping them out. They have something helping them in their journey. And if a patient is is prone to relapse. They're small, have small relapses frequently. They still have the acamprosate when they couldn't take the disulfiram because of the reaction. Clinical considerations, so it doesn't affect the liver, so it makes it a good option for those patients with liver dysfunction. It's 3 times a day per dosing, so that may be good for some patients or bad for some patients. It does appear to help the uncomfortable sensations alcoholics experience after they quit drinking, so it increases the time since the last drink, and there are minimal drug interactions. So there are no U.S. studies that have found this medication to be better than placebo. That's one drawback of acamprosate that's come out in the recent years. The combined study looked at different treatment methods combined and apart, and acamprosate was no better than placebo, and it was not better when combined with naltrexone. So, and the other ones were better. So there's kind of varying degrees of efficacy that people believe this medication has. But if you have a patient who can't take anything else, it still might be a good option given the very minimal risk. So here's a chart that might help you decide when you're comparing these medications, when you might want to use them. So whether it goes to the kidneys or the liver, the cost, how many times a day it's used, that might be really helpful for your patients. Benzodiazepine dependence, there's not a lot of treatment options for this besides tapering them off. One of the biggest things you're going to see is, well, you need to switch them to a longer acting benzo, and then you want to have a very, very slow taper. Okay. You're going to taper over months to avoid rebound symptoms, and you may even add on one of those anti-kindling, anticonvulsants short term to help them with the symptoms. But it's a very, very slow taper over several months. The longer, really, the better. Opioid dependence. So this is a very important one. It's been talked about a lot. Even in South Carolina, we just had a new law passed for it in April, and we'll talk about that in a minute. So for opioid intoxication, we have a treatment option of naloxone. It is an opioid receptor antagonist, and it can be given in IM, IV, subcutaneous, or intranasally every 2 to 3 minutes until breathing returns or a total of 10 milligrams has been given. It has a very rapid onset, but it may result in cardiac and respiratory events, so hypertension, tachycardia, and pulmonary edema. But when a patient has opioid intoxication, I'm not worried about those. The opioid intoxication is the most important thing to treat. So they have naloxone rescue kits. So they're available in most states for emergency public use. You want to call 911, educate the patient on when to use it, how to assemble it, how to perform rescue breathing, and a lot of them are now sold actually pharmacies sell them without a prescription. So the intranasal naloxone that we'll talk about in a few minutes is sold, I believe I have a picture, further on. It's sold at pharmacy without a prescription. You can write a prescription, and it is it'll be covered by the insurance. And in a few minutes we'll talk about the law that prescription is actually required now in South Carolina if you have a certain dose of opioids. But it's they're very easy to use intranasal naloxone administration. So opioid withdrawal itself is not life-threatening; it's just uncomfortable. And so you can see here with the symptoms that they'll go through. Really what we give is give medications to patients that help decrease the symptoms. So clonidine, anti-nausea meds, muscle relaxers, and buprenorphine if we need to as an opioid because it is a partial agonist for the opioid, so it has a ceiling effect. Lofexidine was just approved for treatment of opioid withdrawal symptoms. It's a centrally acting alpha agonist that decreases norepinephrine, so it is similar to clonidine in its effect. Its precaution will make sense: hypotension and bradycardia and QT prolongation. And it has an onset within 6 hours and can be used for up to 14 days. And it has a few drug interactions, strong 2D6 inhibitors and medications that prolong QT interval. Let's see. Opioid maintenance medications. You want to give enough. You may want to give enough opioid to prevent withdrawal and then slowly taper them off of it. You want to prevent relapse with naltrexone, and maintenance medications you can use buprenorphine naloxone or brand name Suboxone, and methadone are both used. Now the combination buprenorphine naloxone and methadone require special training by physicians for use of opioid dependence, and they require an XDEA number. I believe that it's just recently changed by the FDA that or the DEA, if you have less than 30 patients, I think you can get an XDEA number without doing the extra education. But you'll want to check with the DEA and then your state regulations before you prescribe either of those for pain, for opioid dependence. Now, methadone can be used for pain relief, and that doesn't require the DEA number, the XDEA number, but the substance abuse does. The combination buprenorphine naloxone or brand name Suboxone is good for a patient with treatment withdrawal, and it can put someone in it because it is a partial it's an antagonist partial agonist, so it has a ceiling effect. So if they've had a really high if they've been on a really high opioid and they take this, they've now dropped that effect, and you could put somebody into withdrawal. It is a sublingual tablet, and I think I'm not sure I think they took the films off the market. So it dissolves in the mouth. The benefit is a patient can get a prescription filled at a regular pharmacy, and they can get a 30-day supply, unlike an opioid replacement clinic. And it has less abuse potential than methadone. Qualified physicians may treat patients in an office-based practice. Physicians are limited to 30 patients the first year, and then can request an increase up to 100 patients from the DEA. Here's your dosing, your mechanism of action, side effects. You can see here the drug interactions and monitoring. Really, the monitoring is going to be, LFTs and then urine drug screen to make sure that they're not taking something else. And for patient education, you want to avoid benzos. Place the film or tablet under your tongue until it's dissolved. It won't work if they swallow it. And it takes 20 to 40 minutes to alleviate withdrawal symptoms, and you want to be alert for difficulty breathing, including possibly while sleeping. There is a new dosage form, a long-acting implant, which requires training, and there's an extended release subcutaneous injection, which is only available through a restricted program, which you would be looking into if you are, working at a substance abuse clinic. So, one good thing about the buprenorphine also, or the Suboxone, is I've had patients in the past who've gotten a prescription for it, and they'll actually come into the pharmacy, twice a week and get a tablet. So they're not taking it routinely, but they're like, I know the weekend is always really rough, so I take it. So I keep it with me, and I take it on Saturday so that I can get through the weekend. Or they'll come and get 2 or 3. That also helps if it's too expensive for the patient. So it gives them a little bit more freedom than a methadone clinic, but it's not as effective isn't the right word. But the methadone clinic, if the patient's taking their medication, they're taking it routinely, it's not best for all patients to be able to do that, but it does provide a little bit of flexibility. Methadone can only be used for maintenance treatment through a methadone maintenance program. So there are DEA requirements and SAMHSA requirements and that go into these places. Client is tied to their methadone program. There's a greater abuse potential than buprenorphine, and methadone is still the treatment of choice for patients who are pregnant and opioid dependent. It is a Schedule II narcotic, so I believe this used for substance abuse can still only be prescribed by a physician. I know that nurse practitioners here in South Carolina are able to prescribe, are able to continue pain medications, or maybe they can do up to a 5-day supply, but I'm not sure that has extended to methadone clinics. I don't know if that's the current law. Methadone is a full opioid agonist. It has contraindications, so the ones that are going to be with any opioid, and has a duration of 24 to 36 hours, which is why we use it. It must be given in an opioid treatment program. You start at a low dose and increase it, and you increase it slowly because the duration will actually build the higher dose the patient takes. So you'll increase it, 15 to 5 to 15 milligrams every 3 to 5 days, and you'll sit and wait for several days, and then you'll keep continuing up if you need it. I've seen patients who need 10 milligrams a day, and I've seen patients who need 320 milligrams a day to maintain their maintenance from other opioids, and they function just fine. I was amazed how besides coming to get their dose at 5 a.m. in the morning, you would never know that they're on it. Concomitant use with high-dose benzos may cause respiratory depression, so a lot of clinics require patients to take urine drug screens to make sure they're not taking any other medications unless it's been approved by the clinic. Here are your drug interactions, precautions, and adverse effects. You can read through those. Patient education, we've already gone through that. It's a great option for maintenance of abstinence. Here are your facts comparing each of the two. Your commonly used adjunctive medications. Again, we talked about these earlier, but they're really good for controlling acute symptoms. The naloxone nasal spray that we talked about earlier, it's now available over the counter without a prescription. If you write a prescription for it, a patient's insurance may pay for it. It's growing a lot how much how much insurance will pay for the naloxone. That increases the chance that the patient will get it, and some pharmacies are requiring a patient to have a prescription before getting opioids. And actually here in South Carolina, it's law that if a patient is over 50 morphine milligram equivalents, then for their dose, which you can easily get to if you're writing oxycodone or Percocet, then it is required to offer the patient a naloxone prescription. There's really no drawback to it, and you'll see in the slides coming up, because anybody can get it. I could get it if I was worried about my parents because I was worried about the amount of opioids they were taking, or if I was worried about myself, or my wife was worried about me taking it. They could get it just in case something happens and I forget to take my dose, or somehow I take more than one. It's not just to prevent an overdose that's on purpose. It's to prevent an accidental overdose, or if somebody else in the house accidentally takes the medication. So it's really important to offer this to a patient. I would go ahead, please get in the habit of writing a prescription for it and sending it with the opioid medication, because the worst they can do is leave it on their file until they decide they want it. I think it runs about $40 without insurance coverage, and less when the insurance covers it, and that's growing. So back in 2015, we had a law that was passed in South Carolina that allowed prescribers to prescribe standing orders for opioid antidotes to first responders and persons at risk for overdose and their caregivers. So the person who's prescribed the medication does not have to give approval for them to get this. If I was taking opioids, my wife could go and get it and keep it, and I would never know. But she's got it in case there is an accidental overdose. So, and also that we were able to give this to police and firefighters, EMS, so that they could treat patients for potential overdose out in the field, and not have to wait for the patients to get to the hospital. It also enacted the SCRIPS program, or the PMP, you may have heard it called, Prescription Drug Monitoring Program. So controlled substances 2, 3, 4, and 5 go to this central database where you now have to log in every time you prescribe a medication. You have to look and see whether you're a treatment center or not. Unless you're an inpatient hospital, I believe unless you're treating inpatient patients, You have to check the scripts program before you prescribe a controlled substance. And pharmacies are also checking before they dispense, because we want to make sure people aren't doctor shopping. They're not going from place to place to get multiple prescriptions. You also want to make sure you're not prescribing something and you don't know that their psychiatrist has also prescribed them, Klonopin or Xanax. It's an easier way it's a good way to know what your patients are on. So it's very helpful. There's also the Leon Project that started. It was for first responders to get trained in naloxone administration. And at the time I put this together, I think I did this in 2019. Over 3,000 law enforcement officers had been trained, and from June 2016 to September 2017, there were 100 lives saved because of the training that the law enforcement officers did. If you have somebody who is unconscious, who has opioids lying around them, and you give them this medication, the only negative side effect is that if they get opioids later, and you're talking within the next probably hour, they're not going to be effective. That's it. There's really no negative for giving this to somebody if there's a suspected overdose. They also passed the Good Samaritan law that protects any person who in good faith graciously renders emergency care to help cover for civil liabilities if a person did give that to a patient and there was some kind of somebody wanted to sue for negligence or wanton misconduct or something like that. So it protects the caregiver who gives naloxone to a person whom the caregiver believes is experiencing an overdose. Also police officers, if you happen to come across somebody who was unconscious and who just happened to have a bottle of Percocet and a naloxone in their hands, you're able to give it if in good faith you believe that they're overdosing. So here's a picture of the Narcan nasal spray. That key is just in there for size comparison. It's very easy to give. You stick this part right here up the nostril. You push the plunger on the bottom, and the spray goes up in the nose, both nostrils. Boom, you're done. So what it does is it just comes in and blocks the opioids from being able to work on the opioid receptor in the brain. Here in 2016, you can see the number of Narcan administrations that happened in the state of South Carolina. So it is being used, and we're thankful that it is. The South Carolina in 2016, the Board of Medical Examiners and the Board of Pharmacy put out a joint naloxone protocol where to initiate dispensing of naloxone without a prescription. So persons eligible can voluntarily request naloxone from a pharmacist, and it can go in as a prescription from their provider so that their insurance can pay for it, and that is helping to curb the or improve the use of availability for this. So a patient who voluntarily requests naloxone can get it. They can have it available at their house, and they're able to have access for it. So intranasal is preferred, but IM is also covered in this protocol. Intranasal is preferred just because it is so much easier than an IM injection. There is information that's out there for these patients and these caregivers on what to expect, what to do. Call 911, give them naloxone, begin CPR, instructions on how to give it if it is IM. The website naloxonesavessc.org is a great website to get information on this. It's got pictures on how to use the Narcan nasal spray, so you can get both pamphlets if you want. There's even an auto injector. So this is basically an EpiPen for naloxone. You jam it on the leg and it gives it. So that could be easy also if a caregiver would rather have that. The drawback with that one is I do believe that it's fairly expensive. Possible future treatment options, you can see them here. We're not going to go too in depth on these. They're still being studied. And tobacco use disorder, we're kind of gonna skip through this because you can read through it. There's not a lot new. Bupropion, sustained release, and varenicline or Chantix are our two approved options. You can always do them with nicotine replacement therapy. That is very effective to help wean someone off. The important points I want to say with the patch, because this is all in here. The patch, make sure they change the site that they're applying it, and if it causes nightmares, they need to take off the patch before they go to sleep. That's very common. We have lots of patients who just take it off before at bedtime. With the gum should be chewed until they have a peppery taste, and then they park it between their gum and their cheeks to allow for nicotine absorption. Once that they're no longer feeling it or tasting it, then they want to chew it again and park it until the flavor is gone. So you can continue to chew and park to get the effect, but it doesn't help if they just swallow the saliva and the nicotine. They have to park it in between their gum and their cheek to get effect. Lozenges can also be used. They do cause quite a bit of GERD, so and heartburn. So just watch out. There aren't too many patients who prefer that. The inhaler and the nasal spray, I've never seen them used. They're prescription only. They're outrageously expensive, and I've heard they kind of burn. So I don't know patients who really use those, but they are options if a patient really wants it. You can even use you could even do a patch and gum if you want to, if that what helps the patient slowly taper them off. Bupropion extended release or sustained release, same adverse effects and everything as if we were using it for depression, but you start it 7 days before the quit date. Chantix, you can read about it here. It's a total of 12 weeks of using it. It's very effective, and a good option for your patients. So that's it for impulsivity and compulsivity. If you have any questions, let me know.